Welcome to my channel, and today we are going to talk about megaloblastic anemia. So let's begin. So what is megaloblastic anemia? Megaloblastic anemia is anemia occurring due to deficiency of vitamin 12 and folic acid. So deficiency of either one or both can lead to megaloblastic anemia. Now let's understand why anemia occurs due to vitamin B12 or folic acid deficiency. Before that, let's talk about why iron deficiency leads to anemia. Why iron deficiency leads to anemia. So when there is deficiency in iron, no hemoglobin formation will occur. So iron is required for formation of heme component of hemoglobin. So when there is deficiency of iron, no heme will be formed, so no hemoglobin formation will occur. So this will cause RBC to become microcytic and hypochromic. So this will result in iron deficiency anemia. So for iron deficiency anemia, no hemoglobin formation occurs, which will result in anemia. But why vitamin B12 or folic acid? Why vitamin B12 or folic acid deficiency leads to anemia even though they are not responsible for formation of hemoglobin? The reason is vitamin B12 or folic acids are required in the formation of DNA, which is contained in the nucleus. So in the nucleus there are DNAs. So for the synthesis of DNA we require vitamin B12, but we know that RBC do not have nucleus. Although RBC do not have nucleus, but the precursors of RBC will have nucleus. So what are the precursors of RBC? We know that RBC is formed in the bone marrow. In the bone marrow there are multipotent hematopoietic stem cell which will form myeloid progenitor cells. These myeloid progenitor cell will form proerythroblast or pronormoblast. They will now convert into basophilic erythroblast, that is early normoblast. This will in turn convert into polychromatic erythroblast or intermediate normoblast. Now orthochromatic erythroblast or the late normoblast is formed from intermediate normoblast. Now this late normoblast will finally form into erythrocyte. So we see there are nucleus present in the precursor cells. So myeloid progenitor cell will have the nucleus, pronormoblast will have the nucleus, early normoblast will have the nucleus, intermediate normoblast will also have the nucleus. Now in the late normoblast there will be enucleation of nucleus, so nucleus will come out. Now what is left? The erythrocyte or the RBC will have no nucleus. Normally what happens is that cytoplasm and nucleus should go parallelly, but in vitamin B12 deficiency what happens is that the cytoplasm will jump from one stage to another, whereas nucleus will remain in the previous stage. So as cytoplasm matures from one stage to another, the nucleus will remain immatured and will lag in the previous stage. So in each stage cytoplasm will become bigger and bigger and it will be abundant, whereas the nucleus will remain immatured in previous stage because DNA is not formed. You can say that nucleus is lagging whereas the cytoplasm is leading. So this is the hallmark of vitamin B12 deficiency. So what happens is that at the end RBC and the precursor cells will be big, and this is known as nucleus cytoplasm asynchronicity. So normally precursor cells Normally the precursor cells are known as normoblast and the RBC is known as erythrocyte normally. But in case of vitamin B12 deficiency, precursors in the bone marrow are megaloblast, whereas RBC in peripheral blood smear is known as macrocyte. So this results in megaloblastic macrocytic anemia. So what happens is that in vitamin B12 deficiency there is inadequate DNA synthesis. Because of inadequate DNA synthesis, there will be defective nuclear maturation. So cytoplasmic maturation proceeds in advance of nuclear maturation, or we can say that maturation of nucleus is lagging behind to that of cytoplasm. This is known as nuclear cytoplasm asynchronicity, which will result in the formation of megaloblast and macrocyte. So megaloblasts are precursor cells in the bone marrow, whereas macrocytes are RBCs in the peripheral blood smear. Now we are going to talk about vitamin B12 absorption, how vitamin B12 gets absorbed into the blood. So we know the rich source of vitamin B12 are non-vegetarians and those who consume dairy products, whereas strict vegetarians are poor in vitamin B12. So what actually happens is, when a person consumes vitamin B12, vitamin B12 is already attached to the binding protein. So vitamin B12 along with binding protein, they travel to the stomach. In the meanwhile, salivary gland produces R protein. Salivary gland produces R protein, which is known as haptocorrin. This haptocorrin is also known as transcobalamin 1. This haptocorrin, they travel to the stomach without binding to vitamin B12. Now in stomach there are gastric parietal cells. So these gastric parietal cells, they will produce pepsin and intrinsic factor. So in stomach, this pepsin will cause separation of vitamin B12 from the binding protein. So vitamin B12 will separate from binding protein in acidic environment. Now this free vitamin B12 will now bind to haptocorrin, which was produced by the salivary gland, and form vitamin B12 haptocorrin complex. So this is vitamin B12 haptocorrin complex. This will now pass through the stomach into the duodenum. In the meanwhile, gastric parietal cell was producing intrinsic factor. So these are intrinsic factor. This intrinsic factor will go through the stomach into the small intestine. Now in small intestine or the duodenum, there is alkaline medium. In duodenum, pancreatic proteases will separate haptocorrin from vitamin B12. So vitamin B12 gets separated from haptocorrin due to pancreatic proteases enzyme. Now this free vitamin B12 will now bind to intrinsic factor. This will form intrinsic factor vitamin B12 complex. Now they will travel all the way to terminal ileum. So what happens in terminal ileum? In terminal ileum there are receptors known as tubulin. So tubulins are receptor for intrinsic factor. So the intrinsic factor vitamin B12 complex will bind to the receptor present in terminal ileum. Now once the intrinsic factor vitamin B12 complex binds to the tubulin receptor present on the cells of terminal ileum, the vitamin B12 will go across the cell into the blood plasma by the process of endocytosis, whereas this intrinsic factor will get destroyed. Now this free vitamin B12 will bind with transcovalamine 2 and will be taken to other tissues. So what happens is that dietary vitamin B12 has binding protein which will go into the stomach, whereas the salivary gland produces R protein which is haptocorrin, and it is a transcovalamine 1 protein. This haptocorrin will also go into the stomach. In the meanwhile, gastric parietal cells will be producing pepsin and intrinsic factor, and this pepsin will cause vitamin B12 to separate from the binding protein, and this vitamin B12 will attach to hepatocorrin to form vitamin B12 hepatocorrin complex. This complex will move into the duodenum, and the intrinsic factor will follow into the duodenum. Now in duodenum, pancreatic proteases enzyme will separate haptocorrin from vitamin B12, and this vitamin B12 will now attach to intrinsic factor and form intrinsic factor vitamin B12 complex. This will be taken to terminal ileum. In terminal ileum, there are receptors for intrinsic factor where they get attached. Now the vitamin B12 will go across the cell into the plasma by the process of endocytosis, and the intrinsic factor will get destroyed here. Now this vitamin B12 will combine with transcovalamine 2 protein and will be taken to different tissues. Now we'll talk about pathogenesis. So as we have already said that both vitamin B12 and folic acid is required for DNA synthesis. So DNA has adenine, guanine, cytosine and thymidine. This thymidine is formed from uracil. This thymidine is formed from uracil, which is required for DNA synthesis. So as to understand this concept, we have to understand thymidylate synthase reaction. So in thymidylate synthase reaction, we see this uracil gets converted into thymidine with the help of folic acid, which helps in DNA synthesis. So deoxyuridylate monophosphate gets converted into deoxythymidine monophosphate with the help of folic acid, which in turn results in DNA synthesis. For this process, methylene tetrahydrofolate gets converted into dihydrofolate with the help of folic acid. Now this dihydrofolate will form tetrahydrofolate, which will continue the cycle. So here methyl tetrahydrofolate or the plasma folate forms tetrahydrofolate in the presence of vitamin B12. So vitamin B12 also converts homocysteine to methionine. So for the conversion of homocysteine to methionine, vitamin B12 is required. So in case of vitamin B12 deficiency, this step will not occur. Therefore, uracil will not get converted into thymidine. So we require vitamin B12 and folic acid for the formation of thymidine. Now we also need to remember that vitamin B12 is involved in the conversion of methyl-malonyl coenzyme A to succinyl coenzyme A. This succinyl coenzyme A helps in the formation of normal neuronal lipids, which helps in myelin synthesis. In absence of vitamin B12, methyl-malonyl coenzyme A will not get converted to succinyl coenzyme A. So there will be accumulation of methylmalonic acid and propionic acid. So these are toxic. So they cause damage to myelin sheath. So damage to myelin sheath will mainly affect the posterolateral tract and the dorsolateral tract. So posterolateral tract and dorsolateral tracts are more affected, which results in subacute combined degeneration of spinal cord. So damage to myelin sheath will result in subacute combined degeneration of spinal cord, will also cause peripheral neuropathy, loss of pain and vibration sensation, and hyperreflexia. Pernicious anemia can also lead to vitamin B12 deficiency. So pernicious anemia is autoimmune destruction of parietal cells. So there are autoantibodies to parietal cell which will cause destruction of parietal cell. So there will be no intrinsic factor, so no absorption of vitamin B12. For absorption of vitamin B12, intrinsic factor is must. So without intrinsic factor, no vitamin B12 will be absorbed. This will result in vitamin B12 deficiency. So in pernicious anemia, there will be autoantibodies to parietal cell. This is an autoimmune disorder where autoantibodies will be directed to parietal cells, and this will cause no intrinsic factor to be secreted. So there is no absorption of vitamin B12. So pernicious anemia will lead to vitamin B12 deficiency. This will also cause atrophic gastritis, which may lead to gastric adenocarcinoma. The most common site of gastric adenocarcinoma is fundus. Pernicious anemia can also cause gastric atrophy and peripheral neuropathy, whereas vitamin B12 deficiency will lead to stomatitis, glossitis, gastric atrophy and peripheral neuropathy. Whereas in folic acid deficiency, there will be no peripheral neuropathy and no gastric atrophy. Folate transporter gene mutation is present on chromosome 21. Now coming to the diagnosis of megaloblastic anemia. So what are the findings seen in peripheral blood smear? Peripheral blood smear shows characteristic triad of macro-ovalocytosis, hypersegmented neutrophil and Howell-Jolly bodies. So the earliest finding is macro-ovalocytosis, where mean cell volume is more than 100 femtoliter and the diameter of RBC is more than 9 micrometer. Hypersegmented neutrophil is most specific for megaloblastic anemia. So the normal neutrophil has 3 to 5 lobes, but in case of megaloblastic anemia there are more than 5 nuclear lobes. Now there will also be presence of Howell-Jolly bodies. These Howell-Jolly bodies, they are the remnants of DNA, and MCHC will be normal. So when we look at the RBC, because of ineffective erythropoiesis, you will see Howell-Jolly bodies, which will represent remnants of DNA. You are also going to see basophilic stippling. So these basophilic stipplings are ribosomal inclusions in the RBC. So they are ribosomal inclusion in RBC, and these basophilic stipplings are mainly stained by Romanowski stain. So basophilic stippling is stained by Romanowski stain and not by Pulse-Prussian blue stain. Pulse-Prussian blue stain is for staining the iron, and this fine basophilic stippling is seen in megaloblastic anemia and thalassemia, whereas coarse granulation or coarse basophilic stippling is seen in lead poisoning and sideroblastic anemia. We also see Cabot's ring. Cabot ring is a loop or figure of 8-like appearance of cytoplasmic structure in RBC, and it is made up of DNA. It is because of ineffective erythropoiesis we also see it in megaloblastic anemia, lead poisoning and hemolytic anemia. Now coming to bone marrow biopsy or bone marrow aspirate, the best site for bone marrow biopsy in infant is anteromedial aspect of tibial head. anteromedial aspect of tibial head. So this is the most common site of bone marrow biopsy in infant. In children and adult, best site for bone marrow biopsy is posterior iliac crest. So what are the bone marrow findings? Normally, myeloid to erythroid ratio is 3:1. That is, ME ratio is 3:1. But in case of megaloblastic anemia, there is reversal of ME ratio. That is, ME ratio decreases. Because myeloid is normal and erythroid continuously increases, so ME ratio decreases in case of megaloblastic anemia. In megaloblastic anemia, there are large cells. These megaloblast cells, they find it difficult to pass through small vessels, so it undergoes hemolysis. This will result in erythroid hyperplasia, which will result in bone marrow hyperplasia. Also, in megaloblastic anemia, there is decrease in reticulocyte count. So reticulocyte count decreases. You will also see nucleocytoplasmic asynchrony and sieve-like nuclear chromatin will be seen. So this is an overview of megaloblastic anemia.